everyone. Well, good evening. Thank you so much for being with us tonight. My name is Mary Lou Cameron. I'm the Bilingual Program Support Manager at Bladder Cancer Canada. Thank you so much for joining us for this event tonight, Bladder Cancer Grading, what it is, why it matters, and how we're working to make it better. During this session, we will discuss how bladder cancer grading works, including how it's used in treatment decisions, its strengths and weaknesses, as well as updates on research. We will also be moving on to a Q&A session at the end, so please feel free to write down any questions you may have. Please remember that the content of the webinars are for informational purposes only and should not be considered medical advice. Always consult with your doctor and or urologist about what is best for you. And for tonight, I'm honored to introduce our speaker for the evening, Dr. David Berman. Dr. Berman is a professor of pathology and molecular medicine at Queen's University. His research focuses on basic, translational, and clinical aspects of bladder and prostate cancer. He is also a valued member of the Bladder Cancer Canada Medical Advisory Board. I'll stop my screen share. So, Dr. Berman, thank you so much for being with us tonight, and the floor is all yours.
It's really a pleasure. I really want to thank everybody for showing up tonight. And I'll be joined by Grace Bowry, who's a master's in nursing student at Ottawa, who is having a little trouble signing in, but she may be joining us anyway. She helped put this presentation together and has done some work with bladder cancer caregivers and patients on education. So I wanted to point out that this is teamwork done by a pretty large number of students and both graduate and undergraduate students, mostly at Queen's, as well as resident physicians, physician collaborators, urologists, computer scientists, and a whole host of people who we are proud of bringing into the bladder cancer research ecosystem to improve the lives of patients. So we'll explain how bladder cancer grading works, why it's used, and its strengths and weaknesses. We'll share some updates on research from our lab, and we'll ask for your feedback today. Your feedback's important because this is research that's funded by Bladder Cancer Canada, and many of the volunteers work very hard to raise this money. And it's also been funded by the Ontario Institute for Cancer Research, which is taxpayer money. So we have an obligation to do the work that the bladder cancer community values, and we're really humble about this and really interested in getting feedback and making sure we're giving you value for the work you guys do. So a little bit about how bladder cancer gets to the point where it gets graded. As most people know on this call would know that signs and symptoms of bladder cancer, like blood in the urine or painful urination, will bring a patient to the attention of a physician who may refer the patient to a urologist, who will then, if the clinical suspicion is high enough, do what's called a cystoscopy, putting a camera and into the bladder. If they see a tumor, they will take pieces of that tumor. And at the magnification level that the urologist can see, they can't really be absolutely certain it's cancer. And even if it is cancer, they usually can't tell the grade and stage, which we'll define in a minute, and which are critical for planning treatment and management. So the tissue comes out, it goes to the laboratory, and people like me, you can see the resemblance here. We are trained as pathologists, and we look at the cancer as a microscope slide, magnified greatly 100 to 500 times, and answer the questions: is there cancer in this specimen? And if there is, what is the grade and what is the stage? So grade and stage help your doctor plan your treatment and also your surveillance, which are tests to see if the cancer's come back or gotten worse. And they will determine what type of treatment and how often, um, as well as how often surveillance is recommended. So most people divide bladder cancer, or most of the doctors anyway, divide it roughly into um, non-muscle invasive and muscle invasive stages, and we'll talk about that a little bit more in a minute. Um, but those are different stages of cancer, and again, I'll explain that more in a minute. But the early stage cancers that have not invaded into the bladder wall, they get local treatment through the resectoscope, and the cancers that invade into the bladder wall, they get more radical treatment. They're often recommended to have removal of the entire bladder. So grade and stage are prognostic tools, tools used to predict cancer's behavior. The word prognosis means predicting the course of a disease, including whether and how quickly it will improve or worsen. Cancer stage is probably the most important determinant of how dangerous a cancer is. Um, but it's not always the most useful, and I'll explain that in a while. But it tells you how far the cancer has spread. So if it were in a car, it might be sort of like the odometer. Um, Cancer stage, this is again a drawing of the different stages of bladder cancer with non-muscle invasive in the left-sided box, the red box on the left, and the red box on the right is muscle invasive. With this, just going to get a better pointer here. This sort of pink orange layer being the muscle. So these don't involve the muscle. They either don't invade at all, they just protrude into the bladder wall. I'm sorry, the bladder space where the urine is stored, or they invade just a little bit into the connective tissue that sits on top of the muscle. And then the muscle invasive um, involves or even extends beyond this muscular wall that surrounds the bladder and squeezes it to um, help expel the urine. Um, Grading is most important in the early stages where we don't yet know whether the cancer is going to be dangerous or not, and that's the grade is going to tell us, kind of predict whether it's going to spread or not when it hasn't yet spread. There are two types of non-muscle invasive bladder cancer, the flat type, which is also called carcinoma in situ. This is relatively uncommon and has a worse prognosis. And the most common type is the papillary type, which looks like a tree or a broccoli head. And the main risk here is that it comes back after it's removed or it recurs. So these are treated locally and they have excellent prognosis. Um, the grade is how the main way we provide prognosis for these papillary cancers, and it predicts how fast cancers will grow or spread based on how abnormal the cells appear under the microscope. So on the left, we have a low-grade cancer, and these purple ovals here, these are the nuclei of each cancer cell. They're relatively round and uniform, and it almost looks like if you can take a comb and comb from bottom to top, and many of these nuclei will be aligned in a way that they look like a comb has run through them. That's a makes this cancer look relatively organized compared to the high grade on the right, where the nuclei seem to be in relatively random locations, not sort of respecting each other's space, more crowding, uh, don't have that combed appearance. They also have uh, darker, they're darker, which has to do with um, activity of the nucleus in terms of proliferating to make new cancer cells, and also just poor regulation of cell size. So there's variation in nuclear size and shape. So the low-grade uh, papillary cancers have excellent prognosis. The high-grade usually have good prognosis, especially if they're caught early and treated properly. But the treatment varies very dramatically. So low grade gets less frequent surveillance and not much therapy other than just removal, whereas high grade patients can be recommended to have literally dozens of installations of BCG immunotherapy, which many of you are probably familiar with, that gets basically squirted into the bladder through a catheter that has to stay there for many hours. And, each of those, up to 2 dozen or more trips to the hospital can be a major cost to the patient in terms of having caregivers or being a caregiver, days off work, days away from home, etc. So it's really important to get this right. Um, the way grading works at the moment is we look for those things I was talking to you about, like how the cells are arranged, the size and the shape of the cell nuclei, their color, how speckled they are, and how often there's dividing. There are actually these shapes we can see that look like spider webs or eyelashes that cells make. This is called mitosis, and um, it's the way that cancer cells divide. We can see that under the microscope. Um, I just want to point out, if you look at how often cells are dividing, low grade is rarely and high grade is often, but every pathologist probably has a different definition of rarely and often. And so it turns out that none of these features that we're looking at currently have real measurements and cutoffs for low grade and high grade. And so that leads to disagreement between pathologists. And it means that a patient with the same cancer may get a different therapy depending on which hospital they go to and which pathologist looks at their sample. Um, so we did a study looking to see what agreement rates are between expert urologic pathologists who are super specialized and only diagnose or mainly diagnose cancers that urologists take out. So bladder's a big part of their practice. I'm one of these pathologists. And we found that the best we could do was about 80% agreement between each other, but that actually two of these pathologists only agreed with each other 2/3 of the time, meaning they disagreed 1/3 of the time on the same case. Um, so again, it's kind of um, it, it's unclear what treatment a patient's going to get. It's going to depend on which pathologist looks at their bladder under the microscope. And most community hospitals don't have these super specialized academic urologic pathologists. So it may even be a coin flip where your cancer, especially if it's somewhere in between low grade and high grade, not the really dramatic versions of, extremes on either side. Maybe that half of patients are going to get a different treatment depending on which pathologist looks at their cancer. So we think grading should work on actual objective measurements, not on opinions. And we are converting these features that pathologists use to grade, like tissue structure and cell size and shape, or nuclear size and shape and texture. Um, and we're defining cutoffs for these features. And that's how we think grading should work, and we're making some good progress on this project. So we recently published work by Ava Slotman, who was a master's student in the lab. She led this work, and we were able to show that we could use these measurements to grade bladder cancer. And this is the how the paper, the title of the paper appeared in the journal Laboratory Investigation. We published it in 2023, and this is sort of how we did it. So in the upper right, you can see these little tiny pink dots. Each one of those is a 1 millimeter diameter image of bladder cancer under the microscope. And we analyzed each of those image samples using a computer software program that we trained in collaboration with the company that manufactured it, which is called Visiopharm. And we trained it to recognize every cancer nucleus in the image. So on the right here, you can see the output of this software, and it's ignoring this part that I'm circling here, which doesn't have any cancer cells in it. These are blood vessels and benign cells that support the cancer. And then every cancer cell, it's circling the nucleus in white, unless that nucleus is undergoing division, and it's what we call a mitotic figure. Those get circled in green. Um, and so we get measurements of size, shape, location, etc., texture, color for every cancer nucleus, and we get counts of these proliferating cells. And this study was the biggest of its kind, with 371 different patients, 641 images from those patients, and more than 1 million nuclei. So this is now a kind of technology that we can soon have on our clinical desktops when we're practicing pathology. It's starting to come into general clinical use, and so that's our goal, is to make that happen. Um, and so these are results just looking at, on the left is variation in nuclear size, and the low grades, almost all the cases are below this threshold of about 5.5 microns in terms of the average variation in the case. And all the high grades are significantly above, almost all are significantly above that threshold. And similar results with um, the fraction of cells that are proliferating, where the low grades are below 0.00018 or 18 in 10,000, and the high grades are above that threshold. Looking at these statistics for these different ways of grading, these two single feature grades, variation in nuclear size and proliferation rates, were 82% and 78% accurate. And we paid attention to, we wanted to make sure that we wouldn't miss any aggressive cancers. So that's called sensitivity. And we had good sensitivity, 86 and 82% with this just single measurement. And also that we didn't have a lot of false alarms. So our false alarm rates were avoiding false alarm rates. The accuracy in terms of false alarms was a little lower, but it was still pretty good. And then we could improve the accuracy further by combining many of these features into what we call models or formulas. So these formulas or models had between 84 and 87% accuracy, and they did much better in terms of making sure we can detect every high-grade cancer and making sure we didn't have false alarms. So when we do these kinds of projects where we take lots of numbers from a large number of patients, and we actually used artificial intelligence to and something called machine learning to build our best formulas. It's really important to try them out, test them out on a a population of patients from another location, another hospital, where these patients have not been used to train the AI. And so that keeps us from overvaluing coincidental associations. And so this is maybe not the easiest chart to look at, but on the left are the single variable classifiers, variation in nuclear size and proliferation. And on the right are the more complex ones, a simple classifier, a risk classifier, a decision tree, and the AI-based one. And the higher up you go, the more accurate the classifier is, and the narrower or the less variation you have from top to bottom for each classifier, the more likely it is to do well, both in terms of false alarms and making sure it doesn't miss any bad cancers. So this AI-based one was the best one that we had, and it worked very well in a cohort or a group of patients that we obtained from collaborators in Spain. So we were very happy to be able to show that this classifier works not only in Kingston, but on the other side of the Atlantic. That's a really important milestone for us. And we haven't published this part yet, but we're excited about it. Another thing we're excited about is that now that we've defined mathematical formulas for grading, we can do something better. Instead of asking, can we reproduce what a pathologist would call this cancer? We can take the same measurements of nuclear size and shape and proliferation and ask, can we train it to identify cancers that are going to recur quickly after they're removed or recur slowly? And so on the left, you see how well grade does when this is just conventional pathologist grade. So the blue is low grade and it recurs a little bit slower than high grade. So this is on when you go from left to right on this graph, that's years. And this on when you go from top to bottom, it's how many patients have recurred. So you start out, none of the patients have recurred, and then in the top line, about half of them have recurred by 5 years. And in the bottom line, the high grades, it's in a little bit under 2 years, half of them have recurred. Whereas with this new AI-based grading system, we can define a very low risk group of patients who never quite reach 50% recurrence, even out to 7 years. And then the high risk patients recur faster in a year and a half. And the fact that you can see this white space between these low risk and high risk patients means that this grading system works better. And we're excited about applying that to other patient groups from other hospitals. We're getting ready to do that. So what does this all mean for patients? Computerized image analysis can support pathologists in making better diagnosis. It doesn't replace pathologists. It just helps us do a better job. It can improve the accuracy of bladder cancer diagnosis and better selection of treatment so that patients who need BCG will get it, and those who don't need it will not have to suffer through or show up for it when it's not doing them any good. And what's next is, you may remember I told you we did all this work on small images because we didn't want to overwhelm our computer programs or our computers for that matter. But these small images are not the way you actually diagnose patients. I diagnose them using whole slides like this. So instead of one or two of these little dots, I have this much cancer tissue that needs to be examined and entered into these formulas. We're almost done making this whole slide software work. So that's been really challenging, but it's very satisfying to get to where we've gotten. And once we do that, we'll be validating or testing the new grading system that I showed you with that better identifies patients who are going to recur slowly or quickly. We'll do that in patients from other hospitals and in other cities. And after that, it'll be spreading the word to urologists and other pathologists to try to get this implemented um, by pathologists. So that's all the information I wanted to uh, update you with in terms of what we've been doing. Um, and these are the questions we have. Is this research valuable to you? What should we be doing more of? What should we do less of? So I'd love to see comments in the chat, or I don't know if hand raising is available. And if we'll probably also ask Bladder Cancer Canada to send out emails or announcements, giving folks an opportunity to answer a short questionnaire, give us some feedback. And I will stop sharing my screen. Um happy to provide a copy of this material to anybody, or I think Bladder Cancer Canada is going to be recording it, so that might be another good way to receive this information.
Yes, the webinar is recorded, so that'll be available and then uploaded as well to the YouTube channel and to our website in the upcoming weeks as well. We have one question here already that came up in the chat, so I'll read it out loud. The question is, how does spreading the word to urologists and other pathologists happen?
Great question. So a lot of times we'll go to bladder cancer meetings or urology meetings, and we will submit abstracts and papers to those meetings. And when we're lucky enough to get invited to present our work, which thankfully happens, we meet them there and discuss our work, either beside a poster that describes the work, or if we're on the stage talking about it, people will ask us questions afterwards, and usually there's a chance to discuss it after that. The publications also help. And once, the really practice changing things get incorporated into guidelines where urologists have meetings to discuss which of the new knowledge and procedures are going to be incorporated into standard practice. And that's my dream would be to have this type of grading incorporated into the AUA guidelines or the European guidelines, the Canadian guidelines for urology and pathology. Does it apply to upper tract tumors as well? That's a great question. We haven't tested it. It's the same grading system, so I would expect it to, but I think it would be important to actually specifically apply these techniques to those upper tract tumors. And again, I'm very excited about the opportunity to see how well these features predict time to recurrence. And another thing we're planning to do in the future is time to progression. So that's when the cancer goes from non-invasive to invasive, or from superficially invasive into the lamina propria, into the connective tissue, all the way to muscle invasive, the deeper, more deeply invasive cancers.
Another question here in the chat. Are there any planned studies using the new AI tool called Evo 2?
Look it up.
Yeah, no worries. I'll read another question then. Um, so someone that was diagnosed with high-grade urothelioma came from a urine test. They said they were lucky that it was not muscle invasive. Is there any new types of treatments available? I think perhaps that question is asking me if there's a treatment that's not BCG, if I'm understanding
Yeah,
correctly.
there are. So There are a lot of new immunotherapies and some chemotherapy regimens that are in clinical trials, mainly for people whose cancer returns after BCG therapy. So if BCG doesn't work, there are a lot of alternatives that can be accessed through clinical trials. Um, yeah, chemotherapy and immunotherapy agents.
Thank you. I see I have a raised hand here. So it says, thank you for an amazing research and presentation. It was interesting to see the integration of machine learning in the diagnosis process. Could you elaborate a bit more on this, please?
Okay, so I the way I certainly not I'm not a terrific expert in this. I don't do coding, but the way I understand the machine learning process is that it allows us to test every possible combination and every possible threshold of each of these values that we're studying. Um, and so you can imagine, uh, I put up that slide that said, we're going to have 15% variation as the threshold for low grade and high grade. Well, it would test 15% um, uh, in it would divide up the all the cases we have, let's say split them 50-50 or 80-20, and then ask, uh, how well does 15% work? And then it would randomly assort them and split them again so that some patients were, uh, so that you're getting just different, you don't, you avoid certain outlier patients are going to skew your data. So you resample the data like hundreds or thousands of times, and you find the thresholds that work the best. Um, Another example is you then can put those into what are called decision trees, where you could say if the nuclear size varies by 15% and the mitotic activity is above 0.00018 and the nuclear color is darker than a certain value, then that's high grade. It will There are machine learning algorithms that will try, they will find every possible version of that combination of features that best distinguishes the different high grade and low grade. And it will use all of them and then ask for a vote. Um, and so when you're voting across all of these thresholds, each of which works fairly well, at least for a subgroup of the cancers, and you get a majority vote, it's called a random forest, and it's a very robust way to develop. It's a very robust form of these machine learning based tests. I wish I was more expert in it, but it's about the best I can do explaining it.
That's a great explanation. Thank you. Um, an interesting question here. In prostate cancer, are there any parallels in cell types and potentially grading that can come up?
So prostate cancer is a very different algorithm in terms of grading, where we don't use nuclear size and shape for grading. It does help me decide whether something's cancer or not, but once I decide it's cancer, the grading is done um, on the basis of the extent to which the cancer cells make circles and that those circles are surrounded by benign supporting supporting tissue, connective tissue or muscle. Um, so I think it would be possible, but more challenging to make a similar grading system for prostate cancer. Most of the AI-based prostate cancer grading systems are just simply pattern recognition, which is a different type of AI, where they just ask a bunch of experts, what does this grade look like? What does that grade look like? What does that grade look like? And it develops the ability to recognize the sort of the majority opinion of a bunch of great pathologists. What I like about what we're doing is it allows us to take apart grading and make it work better. And that other system I just described, where it's pattern recognition, doesn't actually allow you to do that.
Thank you. That's a good segue, actually, I think, into the next question we have here. Someone is asking if they can trust their initial diagnosis. So, with this new AI research, is it possible to receive a different, in this case, less severe diagnosis? For instance, going from high grade to low grade NMIBC.
Um, it's possible, but we're not, I mean, we don't have a clinically validated product. You could, if you uh, don't trust your diagnosis, it is always possible to get a second opinion in pathology, and somewhere between 1 and 5% of all sort of important actionable pathology opinions are going to be changed in such a second opinion. Um, I, I think that's the best I could recommend at the moment. Again, there are one of the things that's frustrating, but also important sort of safeguard to patients in medical research is that we don't get to use these things for clinical purposes until they're peer reviewed and accepted as guidelines. Because otherwise, everybody will go their own way and use their own systems, and we know that that actually leads to worse patient care.
Thank you. One question we had prior to the webinar, someone when they were registering asked this. If you are originally diagnosed with upper tract urothelial carcinoma and it were to have a recurrence in the bladder, would that still be treated as a UTUC, or then would treatment perhaps change?
I don't really know. I mean, from my perspective, I would expect that it would be treated like bladder cancer and not like upper tract, because what we think happens is that uh, people are exposed to toxins in the environment or in cigarette smoke or elsewhere that sit in the bladder and the ureter for long periods of time in between um, voiding, and that can lead to even to mutations in the benign cells that line the bladder. And so every once in those benign cells can get to the point where they grow just a little bit faster than the benign cells that don't have mutations. And you get what's called a field effect. In other words, these slightly abnormal cells can take over a bit, and then new tumors pop up every once in a while. And so I would expect in somebody who had multiple urothelial tumors at different times that's the mechanism, and that the ones in the bladder are going to behave like bladder cancer, and the ones in the ureter are going to behave like ureter cancer, where one of the main reasons they behave differently is just the anatomy of each location. The ureters are small and they don't have much muscle around them, and it's harder to to monitor them and keep them under control before they spread.
Thank you. Looking at the time, I think we can do one more question, perhaps. I see one here. Someone engaging said that. Any idea what changes from a low grade to carcinoma to high grade? This happened to them after over a decade of time. Could this be related perhaps to age? So I think asking what causes that transition then from low to high grade.
Really don't think we know that. I think there really haven't been enough studies about the different transition points, and I think a lot of that is because it requires that you have multiple samples from many patients, and so in a lot of big cities, those samples will the the patient will go to one doctor at the beginning of their journey, and then another doctor at another hospital, and so they're not even available for most pathologists will do all their work at their own hospital, but they won't have an easy time to get samples from other hospitals. So this idea, in terms of what happens, how tumors evolve as they recur and progress is a really important one, and one that our lab is working on in this project and in other projects.
Great. Well, thank you very much, Dr. Berman, for the informative presentation and sharing some research updates as well as answering so many of the questions in the Q&A. If you had any, outstanding questions, please feel free to send them to us. And as we said, please be on the lookout for an email in the upcoming weeks with some further questions from Dr. Berman for research. So we hope you enjoyed this session. We have two more upcoming webinars very soon. So one is actually on Wednesday, June 18th at 6 p.m. Eastern Time, a little bit earlier than we typically do them. And this will address bladder cancer recovery as well as how physiotherapy can help you in your healing journey. We also have another event on Tuesday, July 15th at 7 p.m. Eastern Time, covering aging, sex differences, and bladder cancer. As a quick note, this was a session that was rescheduled from May. So if the title sounds familiar, that may be why. You can register for all these events on our website under patients/upcoming events at the top, or you can scan the QR code that's available right here on the slide with a phone or an iPad. Emma, my colleague, will also be dropping in the chat a link that directs you directly to the patient's upcoming events page. After the webinar, a survey will pop up in your browser. We would also love to hear your thoughts on this session and suggestions for any future presentations. So please take a few minutes to complete the survey. We would really appreciate it. It will also come to you via email through Zoom if you can't do it sometime after the webinar today. If you need any accommodations to complete this survey, or if you have any additional questions or comments, please don't hesitate to call us. You can reach us from 9 a.m. to 5 p.m. Eastern Time at 1-866-674-8889, or anytime by email at info@bladdercancercanada.org. The information here is available for contact. As mentioned earlier, a recording of the session will be uploaded to our website and our YouTube channel in the upcoming weeks so that you may rewatch the session as well. And any questions that were asked live on air would be removed if the person's voice was included. A quick reminder that Canada Walks for Bladder Cancer is celebrating 15 years this year, and we really hope that you will join us across one of our 22 locations in Canada. For 15 years, participants and supporters have helped improve the lives of those affected by bladder cancer by raising over $3.2 million for research and support programs, with the goal of improving outcomes for every bladder cancer patient. Support the work Bladder Cancer Canada does and help raise awareness of bladder cancer by getting involved today. You can register, volunteer, or donate. Everything can make a difference. You can visit the website here, bccwalk.ca, to learn more and to get signed up for the walk. It is taking place on the weekend of September 20th or 21st, depending on the city that you are in. A big thank you once again to Dr. Berman and to Grace Bowry for joining us this evening and providing us a great educational session. We're so thankful for your time, and thank you to everyone that joined us tonight to learn more. Wishing you all a great evening.